Okay, so we are going to discuss pneumothorax and CV line insertion. So CV line insertion, intravenous line insertion can be done with the internal jugular vein or subclavian vein. So there is a very high chance with subclavian vein insertion that you burst the dome of the pleura and you and do this hydrogenic pneumothorax. So a 60-year-old ventilated patient was taken to the OR to insert a subclavian venous line, and the procedure ended with a difficulty in multiple punctures. After returning to the bed, he became cyanosed and started to desaturate. Oxygen saturation 72%, heart rate is 100, BP is 170. So a chest X-ray is given. So this is a typical X-ray of a right-sided. You can see here the demarcation, the right-sided compressed lung because of the tension pneumothorax. So what is your input based on this X-ray? So right-sided tension pneumothorax, is this X-ray adequate for diagnosis? Right side is adequate, left side is chest X-ray is adequate for diagnosis, but in general this is not an adequate chest X-ray as both the costophrenic angles are obliterated. So costophrenic angle. So right-sided is okay. This one is perfect. You can see the both hemidiaphragms and the cardiophrenic and the costophrenic angles. So but here we do not have this angle and do not have this angle, so this X-ray is not adequate, and you don't have the proper bilateral hemidiaphragms. So usually whenever we order a chest X-ray, it should be like this, because you see the both hemidiaphragms, so you can also see the bubble, the gastric bubble, and you can also see here the air under diaphragm as well, because it's very vital if you miss it. So yes, always order a proper chest X-ray. How to read chest X-ray? So there is I have uploaded on the channel. You can the how to read the chest X-ray, I have uploaded in the channel the picture, and it contains all the A, B, C, D, E mnemonic. So what you have to see first, second, third, like this. Okay, so types of pneumothorax: open and close, and simple and tension, and primary and secondary. And differences between tension and simple pneumothorax. So in tension pneumothorax we have the trachea and mediastinum shifted to the opposite side, because this will compress on the mediastinum, so the mediastinum will shift to the left side. So trachea and mediastinum can be shifted to the opposite side. Tachycardia, hypoxia, emergency situation requiring urgent needle thoracostomy in the 4th or 5th intercostal space in the mid-axillary line, then tube thoracostomy in the 5th intercostal space, mid-axillary line. So there is continuous entry of air through one-way valve. For example, like air can go in but cannot come out. So in such cases there is a valve mechanism and can lead to tension pneumothorax. Triangle of safety for insertion of chest tube is anteriorly the lateral border of the pectoralis major. For example, this is your arm and this is your chest. So this is, let's suppose, wait. So let's suppose we have this chest, you have your pectoralis major muscle here, so it's lateral border. Okay, it's lateral border, and mid-axillary line here. This is axilla, this is mid-axillary, this is anterior axillary, this is posterior axillary. Or you can say the anterior body of the latissimus dorsi. A line drawn. So here nipple. So we have this the imaginary line. So this is your triangle of safety. But remember, they are not interested in lateral border and anterior border of the muscles. No, you have to tell them that axillary lines. They are more interested in axillary lines. So you can say alternatively that this is important, because you have to mention the axillary lines, the mid-axillary line, the anterior axillary line, and maybe they will tell you practically to show us that where is the axillary. So okay, so let's suppose this is arm of the patient and this is chest, and you have Okay, so here you will show them the lateral border as anterior axillary line, the mid axillary line, and the posterior axillary line. So you have to tell this way. So anteriorly the or medially the anterior axillary line, and then we have the mid axillary line, and then the line joining here through the nipple. So this will be your triangle of safety. So usually in the fifth intercostal space on the upper bioder. So here is the diagrammatic representation. Indication of central line insertion. So whenever you want to monitor the fluid balance and fluid resuscitation in very critical ill patient, in TPN, certain fluids and medication, potassium rich fluids, so they can cause thrombophlebitis. So we do these central lines. Failed peripheral venous lines, or you can't achieve peripheral line in shock hemodialysis, transvenous cardiac pacing. Yes, like you want to give medication and do cardiac pacing like adenosine and the amiodarone. Infusion of centrally acting inotropes. So for these purposes you need to have CVP line. Nice guidelines for insertion of the line. Insertion under ultrasound guidance always. Post procedure radiograph for position of the radio opaque tip in superior vena cava just superior to the its entry in the right atrium and pneumothorax to explore them. So these are the nice protocols for line insertion. What are the complications of central venous line insertion? So immediate, it can be arterial puncture, so it can cause hematoma, huge hematoma, it can kill patient, compressing the airway. Pulmonary can be pneumothorax, hemothorax, and chylothorax on the left side especially. And then we have the tracheal injury or an air embolism. Tracheal injury, air embolism, cardiac arrhythmia, tamponade cardiac arrest, infection, thrombophlebitis, sepsis, catheter dysfunction, stenosis of the central venous line, pseudoaneurysm, and DVT. Okay, so technique for insertion of central venous line, IG, internal jugular vein. So it's the typical Seldinger technique. It's the typical Seldinger techniques. So anatomical landmarks for the internal jugular vein Seldinger technique and line insertion. Anatomical landmarks are the mastoid process, carotid pulse, and the depression between the two heads of the sternocleidomastoid immediately above the clavicle. So this is your clavicle. Let's suppose this is the sternoclavicular joint. Okay, this is manubrium sterni, and here we have the two heads of the sternocleidomastoid. Okay, the two heads of the sternocleidomastoid. So you feel here the in this depression the cardiac pulsation, and just okay, so here we have this. Look at the clavicle and two heads of the side. Look at this area. Okay, why mastoid? We mentioned mastoid is the insertion for the sternocleidomastoid. So you will follow that sternocleidomastoid, and then between the two heads of the sternocleidomastoid you will record this triangle or whatever the depression of space. So in the center of the triangle formed by the landmass, palpate the carotid artery and insert the needle lateral to it. So you palpate this area and you will feel the carotid pulse, and just lateral to it. Let's suppose we have here the carotid artery, and so we will have the vein here or the lateral. So just lateral to it, go just lateral to it, and you will find the prick. The needle is directed at 30 angle toward the patient in the coronal plane, aiming towards the ipsilateral nipple. So let's suppose you are doing it on right side. Here is your nipple, so you can go in this direction. Okay, and aspirate. The needle advances as you go forward. You just aspirate continuously. Once the blood aspired, cannulate the vein with Seldinger technique and suture the line in place. So you will have to remove the syringe, and then put the. You must have passed the CP line at this stage. So you just put the guide wire, and then you put the other and so then you can pass the line as well, and then secure it. with aseptic technique. But before inserting, you should hyperinize the syringe as well, so to avoid clot formation. So removal of the removal technique for the line. So head down to prevent air embolism, compress the line of insertion to prevent formation of hematoma. So remove it in head down position like this, and then compress the vein, so to prevent hematoma formation. So here we have the clavicle, where we have the muscle and the two heads of the muscle. So here is your triangle of target. Okay, so right internal jugular vein is preferable to left jugular vein, because straight course of superior vena cava and wider lumen left apical dome is higher and more chances of pneumothorax, chance of thoracic duct injury that may lead to chylothorax. So these are the on the left side there will be more complications as compared to right side. Indication of removal. And plus they can also ask you that why not subclavian, right subclavian instead of internal jugular vein. So in subclavian there is a high chance of pneumothorax as compared to in jugular is safe. Indication of removal: cessation of cardiac support through inotropes, resolution of acute problem, line sepsis, discharge home. Whenever you are discharging the patient, always report this line, or whenever there is a sepsis, line sepsis always. And what is the most common organism? The Staphylococcus epidermidis or albus. Sites for inserting central venous line: internal jugular vein, multiple infusion but not rapid infusion; subclavian vein, risk of pneumothorax; femoral vein, most commonly infected; PICC, peripheral inserter, central line catheter. So these are the different option we have. These are the different option we have for insertion. Okay, subclavian vein, internal jugular vein, multiple infusion but not rapid infusion; femoral vein most. Okay, so organism causing infection is Staphylococcus epidermidis. How to prevent line infection: perform hand hygiene, apply appropriate skin antiseptic, ensure that the skin prep agent has completely dried up before inserting the central line. Use all 5 maximal sterile barrier precaution: sterile gloves, sterile gown, cape, mask, and large sterile drape. So you have to use this to do the central venous line. Once the central line is in place, follow recommended central line maintenance practices. Wash hands with soap and water or an alcohol based hand rub before and after touching the line. So always when you are manipulating the line, so you have to do this, because this is line maintenance practice. Remove central line as soon it is no longer needed. The sooner the catheter removed, the less likely the chance of infection. So this was all about line insertion and pneumothorax.